Hello, everyone. This is Global Health, and today we're talking about non-communicable disease and mental health. Here are our learning objectives. So we've been talking about non-communicable diseases or NCDs throughout the semester, so some of this will be a review, but we'll go more in depth into the burden of NCDs, as well as mental disorders, their risk factors, and cost-effective ways to address these issues with a focus on low and middle income countries. So I think it probably goes without saying, as always, we start with the importance of this health problem for global health, and NCDs actually has a greater burden than communicable diseases in low, middle, and high income countries, with the exception of sub-Saharan Africa. So this is the greatest burden of diseases globally fall within the category of NCDs. This is not surprising to us. This is something that we've been talking about through the semester, is this rise in NCDs globally. We've known that that's been the case in high income countries, but in recent decades, we're seeing just exponential growth of NCDs in basically all regions and all parts of the world. And that, as we know, has a lot to do with development. As we become more developed and adopt more of sort of the lifestyle that we have in high income countries and eating habits, we see more NCDs. And we know that this is going to continue to increase as countries develop economically. The risk factors are related to lifestyle, and a lot of this is within people's control, although we know from a social determinants of health perspective that even that is very much influenced by people's economic status, their environment, the neighborhoods they live in, etc. Now, they're very expensive to treat, but can be prevented at a low cost. So prevention when it comes to NCDs is really key. We'll start just with some key terms. NCDs are diseases that cannot be spread by an infectious agent. They are chronic. In other words, they last a long time. They are not acute. They don't kind of come and end like some infectious diseases, but typically people have them for a long time, and they can be very disabling and lead to death if not treated appropriately. They can also be referred to as chronic diseases or degenerative diseases. Cardiovascular disease, sometimes referred to as CVD, is the disease of the heart and blood vessels. It encompasses both heart disease and stroke. And then cholesterol, which is pictured here, is a fatty-like substance that is made by the body, and it is found in, naturally in some of the foods that we consume, is in particular animal-based products. And the problem with that, as it relates to cardiovascular disease, is it can clog the arteries, as is shown in this picture, and lead to heart attack as well as stroke. So we'll talk a little bit more about that, but just so that we are on the same page of what cholesterol actually is. And then diabetes is an illness caused by poor control of the body of blood sugar. So it is that the body starts to fail to be able to process and control blood sugar. So we'll talk about each of these more in depth. Hypertension is high blood pressure. So this is important when it comes to NCDs because it increases the risk of heart disease. It increases the risk of heart attack as well as stroke, because the blood vessels are making the heart work that much more. Okay, so it can lead to heart failure. And then ischemic heart disease is a disturbance of heart function due to an inadequate supply of oxygen to the heart muscle. So this again is related to high blood pressure. It's related to cholesterol. All of these things affecting the blood vessels and the functioning of the heart. And then stroke is a sudden loss of function of the brain due to clotting or hemorrhaging. Hemorrhaging being bleeding, clotting being, something blocking the blood vessels. So actually in the image there, you can see there's a burst, as well as, sort of different types of blood clots. So one is like a clot of the blood versus one is a blocked blood vessel. So if that stops oxygen or blood flow to the brain, then you see long-term effects of stroke on cognitive functioning and physical functioning. So we'll talk about the burden of these different diseases, cardiovascular disease or ischemic heart disease and stroke, which again, together make up cardiovascular disease, make up 27% of global deaths. This is quite significant, right? So it's causing about 10 million deaths in 2016. And it is the leading specific cause of death globally for all age groups and both men and women. So this is basically the leading cause of death globally. That's really important to know. And it's important to know that it is the leading cause of death for women too, because historically this has been viewed as a men's illness and that heart problems affect men and not women. And there has been the need to increase public awareness and public health campaigns that make women aware of their risk for heart disease, because it is the leading cause of death for women too. Not only that, but increase health professionals' awareness of women's risk for heart disease, because that perception was prevalent even among health workers. And so risk factors or women coming in with signs of heart disease were being overlooked. So there is much more public awareness and professional awareness of women's risk for heart disease because of this increased efforts in public health campaigns to make that more known. So when it comes to heart disease, the risk factors you can see here, there are non-modifiable risk factors, as there always are, things that we cannot change. We cannot change our age. We cannot change our family history because there are genetic, influences. We cannot change our race, ethnicity. But the things that we can change that are modifiable: high blood pressure, smoking or tobacco use, physical inactivity, excessive excessive alcohol consumption, but also high cholesterol, which is of course going to be an outcome of diet, obesity, which is an outcome of diet, and diabetes, which is an outcome of diet. So all of these contribute to, it's important to kind of note that there's so much overlap between these lifestyle factors. So the leading cause of death for in high-income countries and increasingly around the world being NCDs, actually it really boils down to a handful of modifiable risk factors that if we could change these lifestyle factors around smoking, drinking, eating, and exercise, you would actually really see quite a change across the board in the prevalence and burden of these illnesses. There's also huge consequences in costs when it comes to CVD, and that's true about all of these. But I highlight this one because I thought that this study really did a good job of really demonstrating what that cost could be. In South Africa, the direct cost of treating CVD was about 25% of all healthcare expenditures. South Africa being, a low-income country as well. So this really is going to show that this cost is not just something that we see in high-income countries, but we see as NCDs rise globally. 25% is pretty significant. That's a quarter of all healthcare expenditures. And we know that there is high indirect costs too, because this is affecting people at relatively younger ages in low and middle income countries compared to high income countries. And so it's kind of a longer term effect in terms of its burden on the medical system, but also on productivity and economic growth. Okay, diabetes. This is affecting about 8 to 9% of adults worldwide. But as we learned about in our case study on India, it's just kind of rapidly growing in developing countries and in countries that are sort of on a countries like India, Brazil, South Africa that are kind of moving from low income to low middle income and having sort of a real burst in their economic growth. You see sort of this simultaneous burst in diabetes and non-communicable diseases. Now, when it comes to deaths from diabetes, 80% of deaths are in low and middle income countries. And that's because you're not going to have as much adequate treatment. So it's not that there's necessarily more people living with diabetes in low and middle income countries than high, but there are more deaths due to diabetes because of inadequate treatment. And the complications when it's not treated properly are really pretty serious in terms of the effect on the physical health of a person, and of course the cost for treating them: blindness, kidney failure, amputation of feet, toes, lower extremities, and stroke. Risk factors are going to overlap with those of CVD. We have diet affecting being overweight, smoking, physical activity, high blood pressure, high cholesterol, but then some of those non-modifiable factors like being older and having a family history. And I should mention that this is all in reference to type 2 diabetes, which is the type that is tied to these lifestyle factors. There are people with type 1 diabetes that you tend to see them have to get that at any age, like children. It is just sort of the body's own failure to process blood sugar and not related to these lifestyle factors. So if we look at diabetes by region, you can see North America and the Caribbean having the greatest burden. Africa, as we talked about, is sort of that exception where it's still not as high as other regions, but Southeast Asia and Middle East and North Africa kind of coming in second and third in terms of the greatest burden. And then this graph is showing projected rates of diabetes. So diabetes growth in blue, we have the actual burden in 2017, and then in the reddish orange color, we have projections for 2045. And so you can see quite a significant growth, especially in Southeast Asia. You're seeing that basically double. Even in Africa, although it's still low relative to others, it's more than doubling, right? So you're seeing actually it rising across the board in all regions. So chronic obstructive pulmonary disease is also known as COPD. This is a disease of the lung. It basically what it does is it limits airflow through the lungs. So you can see the bronchiole in this image basically being narrowed and also kind of like blocked up with mucus, and this is going to obviously affect one's ability to kind of breathe well and breathe comfortably and get oxygen to all of their parts of the body where they need it adequately. And not surprisingly, the main risk factor is tobacco smoking. Since it is a lung disease, that's not surprising. But when it comes to low and middle income countries, household air pollution is really, we already talked about how that is a problem when it comes to proper ventilation, and using clean burning fuel and things like that are a problem in low income countries. And that has a greater burden on women, who tend to be the ones, and children, who tend to be the ones in home breathing that household air pollution. That's a really big contributor to this in low and middle income countries. This is also affected by outdoor air pollution. as well as occupational exposures. So people working around dust, chemical fumes, or other irritants. So it is a rising problem as well, and we are seeing more deaths in low and middle income countries. Again, this is coming down to a lack of treatment. Moving on to cancer, the burden of cancer. This is a unique challenge because there are so many forms and there can be very different, not only in their characteristics and the way they need to be treated, but also their risk factors. All forms of cancer made up about 16% of deaths in 2016 and 9.2% of dailies or disability adjusted life years across ages and sexes. And then in this image, I think this is kind of interesting. It just kind of shows by region the most prevalent types of cancer. And there's some interesting differences if you take some time to study this, and it should be in your book as well. In the Americas, you're seeing prostate cancer taking up 11%, breast cancer 13%, lung cancer 8%. Let's see if we can see some notable differences. In Africa, you kind of see liver cancer on there where you don't see it in others. You see a little bit less prostate cancer relative to the Americas. And actually quite a difference in cervical cancer. Let's see, cervical cancer in Africa being 14% versus 4% in the Americas. And we'll talk about that on the next slide, but this has to do with getting the HPV vaccine, and it has to do with having, safe sex, because cervical cancer is linked to HPV, is caused by HPV, the sexually transmitted virus. And yep, this slide brings us there where we see what are the leading risk factors for these different types of cancer. And I was just talking about cervical cancer, where you see HPV being the leading risk factor for that. There is now evidence that shows that the virus HPV is a direct cause of cervical cancer. So there is an effective vaccine for HPV. It's most effective when taken at a younger age, for children, but it can be taken up to the age of 26. So it's really important to get that to prevent that risk. HPV is also linked to other types of cancers in men, just kind of a less prevalent as it's linked to cervical cancer. Breast cancer, genetic predisposition, radiation exposure, alcohol use, and postmenopausal obesity. Colorectal diets high in red meat and low in fiber. And for men, alcohol use is a risk factor. For liver, you're going to also see alcohol use, but also these different viruses, hepatitis B and C, being two of those main viruses. Not surprising, lung cancer, we know, is associated with tobacco use, but also asbestos exposure, which is an environmental exposure that used to be used in building materials. So in old buildings, there is a risk of asbestos exposure. Usually you can only be exposed to it if it's been sort of disturbed. So like if you're doing housework or if you're doing construction, and then air pollution. Pancreatic cancer being linked to alcohol use and obesity. And then skin cancer, we know, is coming from sun exposure, so UV light. So sunscreen, of course, being the prevention there. Now, this is not a disease itself, but I think it warrants its own sort of section in this lecture, is tobacco use in itself, because it is the third leading attributable risk factor for death globally. And as we've seen, when we look at these diseases, CVD, these respiratory diseases, cancer, it's a major contributing factor. And what we're seeing is use increase in men in low and middle income countries. And we're seeing also trends in it increasing in women in all regions. And if we were in person, I would ask you why you think that is. And instead, I'll just tell you, we have in the United States done quite a bit to start to limit tobacco's ability to advertise to youth or do targeted advertisement. There's been quite a bit of regulation around tobacco use. So companies are moving their advertising and their marketing strategies to target low and middle income countries. Basically, there's an untapped market in other parts of the world, and because it's become, less popular here because of the knowledge about its risks and because of all of the efforts that have gone into controlling tobacco, they are moving their efforts to be more global. And of course, because of that, we see a rise in it, unfortunately. So the burden of mental disorders, your book puts this with non-communicable diseases. I think in the future, I'll separate this out because it really warrants its own content and lecture, and this is quite light. But they have here different mental health disorders and their definitions, like bipolar disorder, depression, panic disorders, and schizophrenia. Most of these are mood disorders, and they're characterized by changes in mood, as well as for schizophrenia and bipolar, for schizophrenia, it can have hallucinations or delusions, whereas bipolar has these swings between depression and sort of a manic or manic state, right? So when it comes to mental disorders, they're really linked to DALYs or disability adjusted life years. So kind of the quality of life and is really diminished. We know that these disorders that we just talked about, like depressive disorders, schizophrenia, anxiety, and bipolar, are contributing the largest share to that burden of DALYs. And these often start at a young age. They are chronic. They often don't have a cure, but they do have effective treatment. However, depending on the severity of it, it can be hard to get people who are experiencing these more severe mental disorders to stay adherent to their medication. And it can take, quite a bit of work even to get the exact right regimen per person, and dosage and things like that. And so that contributes to a difficulty in treating them. Often people with severe schizophrenia, depression, anxiety, etc., before getting linked to proper treatment, end up kind of self-medicating with substances. And so that creates another layer of a challenge in terms of getting people on treatment, because you're seeing like this comorbidity of mental disorders and substance use disorders. Oh, I think I had this slide out of order. This is just a slide actually going back to tobacco, that I think is really important to think about. And I remember the first time I saw this, I was really struck by it. But it basically shows health consequences that have been causally linked, so a direct cause to smoking or secondhand smoke exposure. So on the left hand of the side, we have smoking, and then secondhand smoke exposure being on the right side. And I just think that this is striking because it shows that tobacco use affects almost every part of the body. I mean, like every serious function, every important internal organ, causing disease, in the cervix, in the bladder, in the kidney, pancreas, stomach. Usually those are linked to types of cancer, but then of course the lungs, you have pneumonia, you have lung disease, COPD, and then the brain, stroke, but also the eyes, blindness, cataracts. I mean, it's really pervasive throughout the body. And then secondhand smoke exposure, this is when we're not smoking ourselves, but we are around someone who smokes. I know growing up in the 90s, it was so normal to be a child in a room full of smoking adults. So we all were exposed to it, and that can have severe respiratory effects on children. It can have long-term effects on their lung function. And even in the more severe cases, it can lead to sudden infant death syndrome. So that's what's known as SIDS. It is a risk factor for SIDS. In adults, lung cancer, nasal irritation, and even in women, having a higher risk for a low birth weight child, which we talked about as an important health indicator on a number of different health outcomes for children, both in their immediate infanthood, but also in their development for both their physical and cognitive development. Okay, so sorry, we're still on smoking. I guess that we might come back to the mental health content, but this just shows smoking prevalence by sex and by region. But then at the bottom, it shows the difference in low and middle income countries and high income countries between men and women. So you can see at the very bottom, the men still have a greater percentage, 36 versus 4% of smoking compared to women in low and middle income countries. But that starts to even out as we get to high income countries. And this probably has more to do with it being like a cultural norm and culturally acceptable for men, but not for women in low income countries compared to high. Okay, alcohol use. Alcohol use has a number of alcohol use disorders that, we like alcoholism and alcohol dependence. There's sort of different diagnosable disorders that are tied to alcohol consumption. And it is a large contributor to dailies globally, the 9th leading attributable risk factor for global deaths. And high-risk drinking increases the risk for a number of things that link to these NCDs that we're talking about. Hypertension, heart disease, hormonal problems, and liver and pancreatic damage. So when we talk about high-risk drinking, we're talking about kind of chronic overuse as well as binge drinking, which is kind of drinking an excessive amount in a short time. And then beyond its effect on chronic disease, it is associated with injuries and high-risk sexual encounters. So intoxication itself can lead to deaths and injuries due to motor vehicle accidents. And it is thought to be a really large contributor to HIV in high prevalence populations because it reduces the use of condoms. Here's a map that shows alcohol consumption per person in 2016 globally. The darker colors are sort of the greatest consumption, and the lighter colors are the least consumption. And you can see that Europe is basically leading in terms of the greatest alcohol consumed per person globally. So now we're going to move to shifting more our focus on addressing the burden of NCDs globally. In the broadest sense, the UN had a NCD meeting specifically in 2014, and they kind of set an agenda for, this recognition of NCDs are becoming the world's greatest chronic challenge across the board, all countries. And so there was this kind of call to action for countries to get their governments to start to build efforts across the board on reducing the risk factors that we know are the main contributing factors to NCDs, so tobacco use, alcohol, diet, and physical activity. The control of tobacco use has a long history in the United States, and it really is considered one of the most important investments in terms of reducing NCD risk. You can see here one strategy that has been used to not only limit the promotion of advertising, basically limiting what companies can do in terms of their advertising, but then going a step further to basically mandate these, labels on cigarettes that really highlight like their negative effects. Australia was a leading country in doing this, so a lot of their cigarettes, they don't have any, like, we're used to seeing the Marlboro label or all these different labels that catch your eye. They have basically banned that, and then every carton basically has something like this that really highlights the risks. Some of them go as far as like showing a really graphic image of like a diseased lung or things to deter people from smoking. And the thing is, we know that this is effective. This is a really effective approach. It's a little harder in the United States to get, the tobacco companies are really litigious. They sue a lot and have a ton of money. So it's been a real battle between government and tobacco companies. They actually, a lot of the regulation they imposed on themselves after in the 90s, there was quite a bit of public reaction because these documents were released by a whistleblower, someone who worked at these companies, that demonstrated that the tobacco companies knew that nicotine was addictive. They knew that tobacco kills, and they had been denying that for years, and they essentially were kind of caught in having all this public documentation of their knowledge and taking advantage of this. And so in the United States, a lot of what we see was them kind of putting their hands up and saying, okay, we will start to regulate ourselves and do better, and was not necessarily an outcome of our government creating those laws. So we still struggle in terms of actually putting those regulations in place on our own. But other countries have been successful in doing that, like Australia. The Framework Convention on Tobacco, I'll talk about on the next slide, but other measures that we know work are really at the legal and policy level. Taxing cigarettes are effective because, I mean, as you might know, it's extremely expensive now to buy a carton of cigarettes because of how heavily they're taxed. This is a deterrent to like smoking because it becomes quite costly to keep up a habit. Legal restrictions on smoking, including, basically in the United States, banning, smoking in restaurants, banning smoking in public places, banning cigarette advertising, and then basically these comprehensive control programs that kind of include all of these measures. So the WHO in 2003 made this Framework Convention on Tobacco Control. This is a treaty, a global treaty that basically created, this is, we know that the WHO is associated with the UN, so this was one of their initiatives. And the treaty has provisions that is basically trying to set, globally, this shared agenda to reduce the effect of tobacco on health. So it has these rules that at a minimum, a government should govern the production, sale, distribution, advertisement, and taxation of tobacco. You can see in the image all the countries that are parties to this that have basically agreed on it, and it's basically most of the world. There are a few exceptions in green that are only signatories. This is inclusive of the United States. This is kind of a classic US thing where we actually never become fully, these like global mandates where it's a treaty that is meant to govern us. We have sort of historically declined to become a full member of those things, but we are a signatory, meaning we will basically, in good faith, work towards this, although there is no sort of there is less legal and there's less obligation to it. And then the gray is basically they did not sign, they're not a member of it, which is, only a few. So when it comes to addressing tobacco, there is actually globally, this is a weakness in terms of what we've seen countries do. Less countries have coherent approaches to reducing alcohol consumption. There is the option, of course, to tax just the same as cigarettes, but the problem is actually in a lot of low income countries and middle income countries, there's a lot of home brewing of alcohol and sort of informal sale of alcohol, which makes taxing it sort of useless if most people are kind of making it. This is common actually in Uganda, where in some of the communities where I work, where there are a number of different sort of breweries where they make their own. Limiting the hours that alcohol can be bought or sold, and then of course like checking of drivers has shown success. And it's recommended that countries sort of implement these policies over time, if they haven't yet, in like a stepwise fashion. So kind of making a plan for the rollout of these over time, which gives companies, organizations, and people that are involved in the sale of alcohol time to sort of adopt the new practices and rules. So with the NCDs that are associated with blood pressure, high blood pressure, cholesterol, obesity, there are efforts to increase food labeling. This is something regulated by the FDA in the United States. The problem with it is that it alone is not as useful if you don't have education for people on how to actually really understand these and use these wisely. A lot of people don't necessarily know how to implement this, so education is needed. Working with producers or actually legally reducing the amount of salt or sugar that's allowed in food is another way. We've seen regulation on trans fat as well. And then, like I said, you need these mass health education campaigns that can be combined with these policy level measures so that people can also make smart choices. It's really difficult in the United States, I think, because you hear so much mixed messaging, because there's like the diet culture that, basically day in and day out, what you think is healthy and what you think is not can change based on what's being sold to you. And even diet culture of, cutting out carbs or all these things that that type of restriction doesn't actually have long-term effects. It can reduce, you can lose weight in a short term, but you typically kind of gain it back quickly and then more. So it's about really getting that proper balance and doing it as a lifestyle change and not like something that you're trying to get rapid results on. So there needs to be quite a bit of work on helping people to learn how to do that properly. It is just challenged by all the advertising that happens around you that is basically trying to get you to buy into the newest approach to weight loss or weight maintenance. With cancer, tobacco control, like I said, is the first priority, but we can also control it with things like the HPV vaccine or hepatitis vaccines, controlling those infectious agents. And then early detection is really, really important, of course, because most cancers are, I'd probably say all cancers are best treated if they're caught early in those early stages. So this means that when like public health and global health measures really need to increase screening efforts and making those mandated, making standards that, at a certain age, everyone gets, prostate, breast, etc., and making that routine. For mental health, the WHO has sort of taken mental health on as sort of a new focal area in recognition that there is rising mental health needs, especially in low and middle income countries, and not so much, not a lot of government policy and not a lot of services in low resource settings. So they have been promoting having a mental health policy at a national level and having a government unit that's actually responsible for mental health. They've been advocating for more budget being focused on mental health programs, and then training primary health workers in mental health. So, for example, in Uganda, we have a lot of folks trying to kind of address, the fact that HIV is prevalent, and then depression and other mental health issues are like a comorbidity with HIV. So how can we integrate mental health support into HIV care? So this is something we've talked about, like task shifting as a way to address human resources for health shortages, especially around mental health. And there's, of course, challenged by the fact that these people are not, it's not actually what they're primarily trained for, and they're overburdened already in trying to deal with just the actual physical health problems of the population. Community-based approaches, though, to psychosocial support, basic treatment and referral, and as I said, task shifting is another focus of mental health. Community-based, being kind of bringing these services to the community and using local structures that can provide psychosocial support. We talked a little bit about that with our refugee populations and the humanitarian crises. How can we kind of bring those services on the ground where we know it's most needed? So a lot of challenges, and these are really kind of wrapping up a lot of the stuff, a lot of the themes we've talked about throughout the semester. The new cases of NCDs are growing because of rapid aging, urbanization, globalization, and lifestyle changes that are happening around the globe. We also are seeing that low-income countries are dealing with this like dual burden, right? And we even called it like a triple burden when it comes to injuries. So you have communicable diseases, non-communicable diseases, and injuries all having a heavy burden in low-income countries, where it used to be just communicable, but now we're seeing it rise kind of across the board. There's also this rapid spread in low and middle income countries that can learn from the lessons of high income countries. We've already dealt with this for a long time. We kind of know how to control tobacco, for example, maybe not fully, but we've had success in it. And so there is the need to take the lessons learned in high income countries and apply them to low and middle income countries. And this is where some of that bilateral and multilateral support can leverage that. Okay, thank you for your attention. That's all.